Thank you. Now we'll hear from Dr. Wong.
Good afternoon, everybody, and thank you for allowing me to share a little bit with you on our workshop that was sponsored by the Roundtable on Health Equity and the Elimination of Health Disparities. Now, I distinctly remember that this roundtable was held on October 2nd in 2014, so please imagine Detroit in October 2nd. The reason I remember this is because on October 1st, the Giants were playing the Pirates in the playoffs. And I'm here on behalf of Jillian Barclay, who is a member of that roundtable as well, and also part of the Aetna Foundation, which was one of the sponsors of this particular roundtable. And Dr. Karen Anderson is here, who's our director of the roundtable, and she can certainly share some perspectives on the roundtable. I should also mention to you, today is an auspicious date. Do you know what today is? It is the 5th anniversary of the passage of the Affordable Care Act. Time marches on very fast, right? It's been 5 years since President Obama signed the Affordable Care Act today. So I think actually this particular roundtable is very apropos. Now, this title of this roundtable, as you see, is quite lengthy. Workshop on digital health strategies, health disparities, and health equity, the promises and perils of technology. So what I have to say, I heard our last two speakers, particularly Dr. Kim. We should have had you at this roundtable because I think many of the aspects of which you touched in terms of engaging youth, Native American youth, and community participation were thematic elements that were very consistent with what we had touched upon, not only in this particular roundtable and other roundtables. So my slides are relatively straightforward, but I'll try to go through them. Let's see if I can go through them. Okay, I'm a proud member. Hey, I didn't put it in. Why Detroit? Why Wayne State? Now, it's interesting. Our roundtable makes a point of touring the country, and not because we're on a little touristy gig, but because we think it's important to look at health disparities from the different communities that are impacted. And Detroit is a particularly interesting community. Some of the worst health disparities are in that city and in that metropolitan area, particularly around infant mortality rates. And there is a center for work focusing on health disparities. Dr. Roy Wilson was the former official of the National Institute of Minority Health, and he's the president of Wayne State. Our focus was, as you can see, how communities are using digital health technologies, investigate community engagement, and discuss the need for models of successful technology-based strategies to reduce health disparities. So as you can see, the emphasis here was very much on looking at the communities that are impacted and how communities have a stake, and as Dr. Kim said, the empowerment issue, not only with individuals, but with communities. These were some of our key themes. Digital health strategies have the potential to both exacerbate and diminish already existing disparities between population groups. And I think this point was made a little bit earlier. There's an opportunity to exacerbate health disparities in health technology, as well as to mitigate and improve on the disparities that we observe. It's not about technology, it's about people. And in this interesting world in the 21st century, in 2015, technology is extremely seductive. We're bombarded every day, actually, about the promise of technology. I was talking to one of our colleagues earlier this afternoon. You know, there are virtual goggles now that one can put on and really experience the whole well, you could go to a basketball game and experience the basketball game from the floor, and it's probably very close that you could put on some goggles and experience the whole hospital patient experience. And what does that really mean? The technology is very intriguing, but having said that, it's still about the people. And technology is the servant, not the master. Community engagement is critical, and we need to look at systems and patterns rather than individual isolated events. We introduced another acronym, DHS, Digital Health Strategies. Why use digital health strategies to reduce disparities? There's already very extensive use of mobile technologies in minority communities. And I would just say, take a ride on your local public bus, and how many of the kids are actually just looking down on their smartphones? And they're kids from the spectrum across the demographic parts of our country. They are engaged in smartphones. And in many ways, the questions of technology and smartphone use is not about the people in this room, but the people who predate you, or I should antedate you, by considerable years. Dr. Kimberly Dawn Winston was also of Wayne State and had been also participating in a number of issues around health disparities. She pointed out that globally, it's not just the United States, of course, globally, more people own a cell phone than they own a toothbrush. And I think everybody's been intrigued by those photographs when you see some of the bush tribes in some of the most isolated parts of Africa use their cell phone, because the cell phone technology does not require hardwire systems. It requires just, a transmitter somewhere within the region. Community engagement, let's see. I got this. Community engagement is critical. And as Dr. Kim said, I think her work certainly was consistent with this. Participatory research is critical. Efforts have to be ongoing. And we need to think about the ways to incentivize participation, not in terms of the stereotypes, as again Dr. Kim had said, but in terms of what's relevant to communities. Align research questions with community and patient needs. And one of the examples that was shared, and I think we actually talked about text babies as well, was in Detroit. They are using phones and text mailing to engage mothers and young families in urban communities to address issues of low infant birth weight. We had a speaker, Wendy Nilsen, and she said very provocatively, mobile technology is where it's at. I don't say that so well. But to illustrate where it's at, we actually had a lunch break that was a bit extended. Maybe this could have happened during our lunch break today, where we invited a number of producers of different mHealth technologies, and they shared at different tables what they were doing. So we saw mHealth applications that had to do with connecting people to healthy food, to connecting people to WIC vouchers, et cetera. Not just the issues of engaging individuals with regards to different health behaviors, but also connecting people to resources. Mobile health, mobile technology can reduce the digital divide, and mobile technology allows for customization of DHT, which is not an insecticide. It is a digital health technology. And mobile technology is useful for centralizing communication across people and systems. This is an interesting slide. MT, mobile technology, is useful for information gathering, and we have an app to track menstrual cycles for, quote, less risky sex, which I thought was kind of interesting. One could argue for better fertility as well. That came out as one of the mHealth applications that are used in different communities. The perils of DHT, pushback from healthcare staff, particularly with regards to the time that requires people to interface with DHT, and making sure technology does not replace the personal interactions between providers and patients. And I also had a conversation earlier today about the importance of the face-to-face. And I think actually one of our presenters talked about the fact that speaking to a back of a head is not really rewarding in your face-to-face interactions with physicians. Health literacy is needed to use these tools. Health literacy came up in our roundtable, because I was there. Little effort is made to evaluate the usefulness and utility of these tools. As was mentioned earlier this morning, that there's very little evaluation in terms of the efficacy of these different mHealth tools and digital health technologies. What about industry? And this was very interesting because we did actually have an entrepreneur who had been very successful in Silicon Valley. And he shared with us some of his pearls. Health and healthcare fields need to work with industry on user-centered design. We need to include young people in the development of products. And they, quote, are instinctively good at this. Now, having said that, part of our conversation, too, as you notice in the papers today, in the last year or so, that the diversity within the high-tech fields is not particularly good. And this was raised as well. If we're going to develop different platforms and different ways to engage young people, shouldn't the people who design and customize for these different health technologies include a wider diversity of individuals from different backgrounds? Essentially, was the question of how do we democratize the issues of development of health technology and industry? There's a disconnect between the development of digital health strategies and where the actual needs are. And we talked about this as well earlier today, financial gain versus improved health outcomes. Where does that really take place? And I think these other concerns, I won't go through them point by point. As you can see them, I think we've talked about these, privacy issues certainly, and who works for who and under what circumstances. Now, this next slide mentions something interesting. It says digital health technologies need to be hackable. A patient who is using it needs to make it their own, or his or her own. And I think this point was shared by the executive director of Zero Divide, which is a nonprofit corporation based out of San Francisco, who looks at the digital divide among vulnerable populations. And they actually sponsor hackathons for different communities and youth to look at different platforms and different health technologies to make them more relevant to their needs. The costs of connectivity are not declining. Access issues still remain, as was mentioned earlier today. So there are certainly issues with regards to reaching people that need to be reached and not necessarily assuming that everybody has access into the internet. We had a speaker from Kaiser-Permanente, and since I know a little bit about this, we made a very large investment in Epic, and it is known as Health Connect, but inclusive of our electronic health record is the platform in which people are able to register for. So if you're a Kaiser member, you can get onto the internet, register as a user, and be able to interface in terms of getting your lab results and getting your prescriptions filled and having interactions, email interactions with your physicians. And we do have the capability at this point to provide, as I think was mentioned a little bit earlier today, for you to take a snapshot, for example, of certain conditions and send that to a doctor for evaluation and get feedback in fairly short time, if not real time. The use of this kind of program has really transformed KP's ability to connect with patients and how we think about healthcare delivery. Indeed, 35% of all the interactions any primary care physician has at Kaiser-Permanente is now through email, as opposed to face-to-face and telephone visits. And this has led to quality improvement in the delivery of care. However, as was pointed out by our Kaiser-Permanente speaker, usage is not equitable across all groups, and he provided us with a very interesting matrix. If you look at people who are or are not registered and who uses the internet access as a member, there are people who don't have it, there are people who have it, and there are people who want it and people who don't want it. And if you square up the boxes, you certainly can have a person who says, I have access, but I don't want to use it. I'd rather just speak to my doctor directly and or to the nurse and have face-to-face visits. And there are some people who definitely want it, but can't get it because of different access reasons. So what is the moral of the story? Please. The use of digital health technologies has the potential to both exacerbate and diminish already existing disparities between population groups. And I would say the caveat to that is engagement of the populations that we really are targeting is the takeaway. If we don't really engage people and the communities that have historically been underserved, it's really not addressing the issues of health equity. So thank you for allowing me to summarize.